So, good evening, good morning, and good afternoon, everybody. I am Dr. Mohanad Insoor. I am the Executive Director of Eastern Mediterranean Public Health Network, EMFINE. We are pleased to welcome our esteemed speaker, facilitator, and audience in this important webinar titled COVID-19, an opportunity for more equitable health systems. We are honored today to have remarkable experts from the globe and from the region to present us with their views and experience on how we can look at COVID-19 as an opportunity for making health system more equitable. COVID-19 pandemic hit the world in a way that has left many, if not all, countries struggling with the need to improve their preparedness and response mechanisms. The pandemic has uncovered many problems in health systems and has allowed us to take a closer look at how best to improve and strengthen health systems to manage, prevent, and protect against public health threats. With the goal of preventing and containing COVID-19, countries have adopted strategies that are similar in nature, but yet different in implementation, as it all depends on how well the health system is prepared and capable for responding. In Eastern Mediterranean regions, this variation has been obviously, especially when we consider that many health systems are already fragile and their ability to respond to such large outbreaks is weak or inadequate in many times. One of the most important lessons gained from COVID-19 pandemic is the need to coordinate efforts and work together to reach and serve affected people by COVID-19. Like never before, within the same country, we have witnessed stronger collaboration between different sectors with a greater emphasis on the important role of the community. The question remains, what we can do to make sure that our health system are strong enough to serve all segments of the populations and that no one is left behind, not just during emergency, but at all times. With this question, I am honored to present our speakers and facilitators in this webinar. For this webinar, the first speaker, Professor Salman Rawaf from United Kingdom, Chair of Public Health, Director of WHO Collaborating Center in the Department of Primary Care and Public Health at Imperial College, London, United Kingdom. Professor Salman acquired his qualification in medicine with a training in pediatrics and public health medicine and was Executive Director of NHS for 26 years. Professor Rawaf is globally recognized for his international work and contribution to global health and health system development. He has published more than 230 scientific papers, 5 books, and international reports, and received many awards and recognitions. For the second speaker for today's webinar, Professor Thameen Siddiqui from Pakistan. Professor Siddiqui has a fellowship in internal medicine, master's degree and fellowship in public health from United Kingdom, and doctoral degree from Heidelberg, Germany. Dr. Thameen Siddiqui is a professor and chair, Department of Community Health Sciences, Aga Khan University, Karachi, Pakistan, since January 2018. Dr. Thameen was also appointed as a senior advisor to the Federal Minister of Health of Pakistan since April 2019. From 2002 onwards, he worked for WHO EMRO, where he served as a Director Health System Development and spearheaded the work on universal health coverage. He has also served as WHO representative to Lebanon and Iraq. Our third speaker is Dr. Bassam Al-Omari from United Arab Emirates, Abu Dhabi. Assistant Professor and Faculty Advisor, College of Medicine and Health Sciences, Khalifa University, Abu Dhabi, United Arab Emirates, and a visiting professor at the Queen Medical Research Institute in the University of Edinburgh. Dr. Al-Omari has PhD in public health and primary care sciences from North Imperial University. Dr. Bassam also had over 20 years of experience in clinical healthcare patient practice with management and education. Finally, I am honored and pleased also to present our today facilitator for this webinar, Professor Musa Al-Ajlauni, Senior Health System Consultant and Advisor. Professor Musa is a professor of healthcare management and well-known international health system expert with over 40 years experience in health sector, working for government and international organizations. Professor Ajlauni also is founding member for Jordanian Association for Hospital Management, the Middle East and North Africa Health Policy Forum, and the Jordanian Public Health Forum. Also, he worked in many universities for more than 15 years as a professor in healthcare management. He published 3 books and dozens of research papers in healthcare management and health policy. Professor Ajlauni, the floor is yours, please. Thank you.
Thank you very much, Dr. Muhannad, and assalamu alaikum. Good evening and good morning, everybody. Thank you, Dr. Muhannad. Thank Infinite for organizing and hosting this important seminar, and thank for your dedicated staff. Our first speaker is Professor Salman Rawaf, and he will present the impact of COVID-19 on health systems and potential lasting effects of this pandemic. Professor Rawaf, the floor is yours, and as you know, you have 15 minutes to present what have you prepared, and after that we have 5 minutes for discussion. The floor is yours, Professor Rawaf. Please go ahead.
Thank you, Professor Musa. Thank you very much for the introduction. It's an honor and privilege to be with my colleagues at the invitation of Infinite. And I'm really grateful to be given this opportunity to share with you some of the answers to the question which are raised by colleagues from the Infinite. I mean, to answer these questions, unfortunately, you have to be critical. And this time, you know, we are still, I believe, in the peak in many countries. Even many did not reach the peak yet of the pandemic. It's inappropriate to be critical, in my opinion. So please, what I'm going to say need to be taken in the context of early stage analysis, because whatever we say at this stage may not be the right analysis of the situation. The dissection and the in-depth analysis will come later, definitely, when we control and defeat this pandemic, and we will. Let me take you what's happened in the world today. If you look at the data, this is from yesterday, from last night, the figure didn't complete for today. We are talking about 13 million people and over half a million of people, unfortunately, with death. But if you look at the Middle East, I just want you to look here. You know, the countries which are most affected, of course, Iran. Now, Iran is one of the top countries in the world. But also you will see that actually Pakistan and this is Iraq, this is Turkey. This is Iraq, this is Kingdom of Saudi Arabia, and this is Egypt. And yet the data showing they are going up and up. And as I said, they did not reach the peak. And if you look at the burden around the world, it's mainly coming now from Latin America. But look at the green. This is Eastern Mediterranean region. This is what's called EMRO. and Iran is constitute the bulk of the mortality so far. And I don't want to go into that sort of detail, but to show this is around the world in terms of the total excess of death. Let us go to this early analysis without being perceived as a criticism in 1 minute. I think almost all countries, with the exception of 3 or 4, which is well known, like Taiwan and South Korea, Hong Kong, Singapore, every single health system were not prepared. So one cannot say, look, X and Y country in the Middle East didn't do well. Actually, most of the countries around the world did not do well. And the 4 which I mentioned, simply because they have long experience with coronaviruses, especially SARS-1 and MERS, you know. And I think I want you to think about this slide, which is fresh from the press, which is some data published today. We are talking about a huge burden and shock to our economy everywhere in the world. You're talking about losses because of the corona, between 9 to 33 trillions. I mentioned this figure because this is very important, because the amount of money which we need to spend to support health system, you know, in the near future are peanuts compared to this. And I want you to remember this, please, because this is very important, because some countries are unwilling to support health system, public health, etc. You know, and all what we need to prevent similar eventualities, you're talking about 20 to 40 billion. I'll come to this point later on. Let us look at why countries adopted different strategies, and most of these strategies, unfortunately, were reactive, even among the richest countries in the world. If you take the 5 top rich countries, most probably the only one which did well is Japan and Germany, relatively speaking. But again, too early to judge. It's about the preparation. I mean, majority of these countries will actually struggle to ramp up most aspect of the services needed in a situation like that. Let us look in details on the ramp up. You know, public communication was very poor. I mean, you notice some countries, the message was very clear: stay home, save health services, save your life. You know, they put the onus and the responsibility on the individuals. And indeed, in many countries, the people beautifully responded, but that is not the case everywhere. The issue is about testing, and we know how many countries failed in testing, contract tracing, critical care capacity. Even in the United Kingdom, one of the richest countries in the world, number 5 in the health economy, you know, global health economy, did not do well on all these things. But there, I must say, public communication was first class. You know, protection, especially healthcare workers, in particular in the early stages. And some countries are still struggling with the PPE, and this is a problem. Data, just ask colleagues at WHO, and they tell you the sort of frustration they are facing because of the poor quality of data, some people hiding it. I mean, recently I heard from a colleague in one country that his political master told him, please, we want the figure to go down. And you know what does it mean? And this is really a disastrous things happen, especially in the Middle East. There were ill-defined and huge overlap between the role of the public sector and the private sector. In many countries around the world, the government decided to take over the private sector to enhance the role of the public sector. And again, we keep saying that any country without a strong public health sector, they face the consequences which is happening now. So the second element is really the issues of governance and leadership. And that at the political level, as well as health service level, and almost every aspect of society, because there is no single aspect of our society not affected by that disease. And as you know, the primary care was not prepared. They were not even involved in the preparedness. There were 3 strategies adopted about primary care around the world. Some of them, they shut down entirely the primary care to protect it. Others, they took the risk, and it was for them a big mistake. The 3rd strategy was the cautious one. Yes, we are open, but we are open online. Hospitals were not prepared. You heard about supply, whether medication, etc., logistic, how to reach different places in especially remote areas. The workforce wasn't flexible enough. We moved a lot of surgeons, for example, from surgical duties which are not needed now into something like critical care. The evidence, and as you know, my God, never happened in the history of humanity that doctors creating fake news and circulating half-baked evidence or no evidence at all. It was absolutely disastrous and worrying. Sitting, I am as a member of the actually technical advisory group for COVID for the WHO. That aspect of misinformation was actually unbelievable. Then we talk about the innovation, and I must say this is thanks to COVID. There is nothing to thank COVID for, but thanks to what happened because of COVID, there were a lot of innovation, a lot of papers actually published on that in a beautiful way. But most importantly, we felt that in the health services and social life, there were fantastic development. And I think this is how the future will be built. The public, some of them were confused. Some of the messages, especially coming from politicians, dismissing member, or let me mention it by name, and I'll take responsibility for that. You know, the chair of the parliamentary committee in Iraq for health and environment appeared on television, said this is a political thing, there is no virus, and he said, I'm a public health specialist. That disaster, you know. So sometimes misinformed. How the future look like? This is a few slides, which I'll finish my presentation, and hopefully we will discuss these things in more detail with the colleagues around the world. I think we need health systems that fit for purpose, and this is very challenging. I know many countries already started to think about that. I challenge WHO publicly, and indeed challenge a few governments publicly, that we need to stop this silly vocabulary which we used it for years. You know, we're talking about health for all. Where is it? Health system for all. Where is it? Equitable health system. Where is it? It's proved to be that we were talking about it since 1978 from Alma-Ata. We know, all of us, how Alma-Ata was suppressed immediately within a few months by Rockefeller Foundation meeting in Bellagio in Italy. But still, these vocabularies will not be accepted anymore by the public. Essential services. What is essential? What is basic? What is non-essential? So we need to look at things in a totally different way. You know, these pathetic things need to disappear from our health vocabulary. We need to look at really different system for primary care. Hospitals. I mean, one of the consultant colleagues the other day said, we can deliver now more than 50% of the services virtually. We don't need the patient to come and see us face to face, and we put them at risk. And we need to invest in public services. And I think this is now not only my conclusion, but conclusion by a lot of authorities around the world, and especially government, which faced that reality. There was a beautiful paper from Italy, there is one from McKinsey, and we've seen it even in China, although the health system, public ones, very, very strong there. But therefore, I'm talking here about smart investment. And what do you mean by smart investment? We need to invest in governmental health services, i.e. public health systems. And that is absolutely crucial. We need to invest in public health function, and in particular, the workforce, facilities, logistics. You know, and I know that almost every country didn't have sufficient public health laboratories for testing, for doing the right things for their own citizens. And it was embarrassment. We need to invest in truly public health measure, you know, and this is even including the health promotion message or the health promotion messages, to be more accurate. Even with this, you know, what we are doing is not enough. We need to do something totally different. We need to look at the prevention from totally different things. Training, continuous training, and we need to tune private and public sector. In many countries, private did not behave in the right way. I know one country, the private sector, there was not a single report of COVID-19 as required by international health regulation and public health laws of that country was reported to the Ministry of Health or health authorities. Why? We don't know. Despite the fact every single institution, with the exception of few, did not seek topic. So COVID, sorry. So this is the tuning and coordination between these is important. This is a fresh reference. I leave it on the slide because there is no time to discuss it. But these are 5-6 key areas for shifting the health system in totally different way, from reactive to proactive one. I think the future also we need to think about how to prepare for emergencies, how we train people for that, what type of governance we require between various elements of the governmental system, various elements of government, but most important things, how the public should be involved in the planning, in the preparing, etc. We, as I mentioned, the primary care role, hospital role will change, especially the issue of using the workforce in different way. The evidence, we need to generate more evidence. I mean, I was shocked that I reviewed the papers on primary care, research paper on the primary care on PubMed. There are more than 30,000 papers published. There are only 4 research on primary care. So this is again big problem. And we, as when we look at the evidence, and there are so much misinformation, and it's very frustrating to have clinicians appearing on television talking about the Russian drug, about this, about that. We don't have treatment. We don't have a new treatment. All the treatment we are using, you know, they are still not proven 100%, and it may work with some patient, may not work with others. So that,
interruption, you have 1 minute.
Okay, I'll finish in 1 minute.
Please.
And public health measures and supportive treatment are the only things which we have. Research and development, I mentioned it important. Involving the public is vital. Forecast very quickly in the last 30, 40 seconds. It's not encouraging. This is from the Institute of Health Metric Evaluation to the end of September. As you will see, 4 countries, which is Sudan, Egypt, Iraq, and indeed Kingdom of Saudi Arabia, they are facing challenges which you need to. The second wave will be there. We don't know how, but it depends on people behavior and how authorities will work, etc. And thank you very much indeed.
Thank you very much, Professor Rawaf, for your comprehensive and informative presentation. And if you allow me, before I open the floor for some questions, to just pinpoint some of the key messages that you have pinpointed. And I like the smart investment, and I agree with you, smart healthcare systems need smart investments, invest more in better health for both health and economic reasons. And we must emerge, as you mentioned, from the pandemic stronger, and learn from the different reactive strategies that have been tested all around the world. And we have to emphasize and create a strong primary health care that can provide a critical first line of defense and response to keep people safe and healthy. And of course, the heavy price of the pandemic, as you mentioned, is that we have to learn from it and to invest and to learn from this crisis and never let a good crisis go to waste, as Churchill mentioned. Thank you very much. And I will open the floor for a couple of questions from the audience. Yes, Dr. Salman, a question. Thank you, Professor Salman, for the informative lecture. Based on the lessons learned globally, what are your key recommendations for enhancing the effectiveness of the health system governance role in addressing the COVID-19 crisis in terms of control, recovery, and impact?
I think I said it. I will
Yes.
repeat in different format what I said. I mean, the issues of governance, al-hawkama, is so important to bring all the element together and avoiding the confusion. We did have in many countries, and again, this is not critical, it's just a preliminary analysis. We will learn more over the next 3-4 months, toward the end of the pandemic. You see, there were no good integrated thinking, put it this way, it's almost everything left to politicians. Scientists didn't come all together to think about the best way. I mean, I know in many countries there were universities almost competing with each other in terms of how to advise government. Certain element, I mean, people in primary care, we just submitted a paper on that. People in primary care, they were complaining that they were not involved in preparedness, even totally ignored in terms of emergencies. Again, people in primary care said they did not receive PPE, personal protective equipment, until very, very late, and it was almost, some of them said, too late. There are a lot of things which you can mention, but the sake of the time, when we talk about governance here, I want to focus on one element which is very important in terms of the collective responsibility. All of us have to be responsible, and that collective responsibility need to bring us all together and jailing us all together.
Okay, thank you very much. Another question, Doctor. How do you expect the delivery of healthcare, particularly primary care, to change after COVID? Do you think that there will be a major change in the delivery of healthcare, primary healthcare?
It's already changed. Oh no, in some countries already changed. That a country without a primary care for every citizen must register with the primary care. Let me tell you from the start, they are not prepared for a future epidemic or pandemic, number one. Secondly, today, the primary care in some countries restricted face-to-face contact to something like 20%. For years, we wanted the primary care to use the technology, virtual consultation, for example. Now, all of them are trained in virtual consultation in some countries. It needed training. Not saying because I know how to manage Zoom, I can't do that, or how I manage the telephone. It's really art. And Some countries already started teaching their medical students and people in training about virtual consultation. Not only that, we are expanding the role of primary care in a variety of ways. A lot of things, you know, like an outpatient, don't need to be in hospital setting. I know from a country that joint consultation between consultant from the hospital and primary care is happening. So it's already changed, by the way, and more to come.
Thank you, Professor Rawaf. Thank you very much again for your answering the question and presentation. Our next speaker is Professor Samin Siddiqui, and he will talk to us about health system response to COVID-19 in lower medical income countries from an equity perspective. Please, Professor Siddiqui, the floor is yours. Please.
Thank you very much. Assalamu alaikum, and good evening and good afternoon to all of you. First of all, thank you very much for inviting me to be part of this session and to give this talk. And thank you, Salman, for giving a very, very nice talk. I really enjoyed connecting with you and, of course, listening to you after many, many years. So it was great to hear that, actually. So thank you very much. I'll be coming and talking about the health system's response around COVID, but I'll talk much more from a low middle income country perspective. And my focus, as you have requested me, will be around equity. So I will pick up some of those equity issues that I think are relevant to us around COVID. So very quickly, and we all know, but I'll not spend too much time, but you can define equity the way you wish to define. But it is about fairness, it is about justice, it is about just opportunity, it is about minimizing disparities as much as possible. And that, I think, is a challenge for our countries. So I would like to spend 2 minutes before I go that while we'll talk about issues of equity and COVID, but we must realize we are living in a region and we are living in an environment where there have been huge inequities in health prior to COVID. And I think it is these inequities which have really been thrown bare and have exposed our health systems as a result of COVID. So let me just spend a few minutes on a couple of these slides. So if you look at, this is the look at inpatients admissions. On the left are high income countries and on the right are the low income countries in this figure, if you can see this cursor. And what you see is that in the high income countries, it is the poorest, which are people in this blue bar, which take admission. So more than 10% of the people in the poorest quintile have admissions in high income countries. Whereas if you look at the low income countries, it is the poorest who get much less admissions for inpatient care. And that shows the kinds of inequities that we have and we have had for many, many years in many countries of our region. And the same is the case for, if you look at pap smear, and I will not get into the details, but these inequities have been in our countries for years. So I've picked up 5 EMR countries, and these 5 bars for each country show the quintiles by income groups. On the left one is the poorest, and on the right one is the richest. And if this is 4 visits for antenatal care, and you will see that Egypt is not doing bad, although the poorest has around 65% antenatal visits, while the richest have 90%. And I think Jordan is a good example, as you can see, where over the last 10 years it's done pretty well. And Pakistan is catching up as well. But if you look at the extremes of Yemen and Afghanistan, you can see that not only the levels of coverage are low, but there are substantial differences across income groups. Now, similarly, this is a slide which is a global slide. The dark green bars are the rich countries and the orange bars are the poor countries. And what it is showing is that over 14 years, and this is a UNICEF data, that the stunting has actually increased in poorest countries, whereas the gap in the richer countries has decreased. And so these have been prevailing and continuing in our region and in many of the LMICs over many, many years. If you look at the inequities from a financing perspective, then you can see that here, this is the one that I want you to focus, the highlighted bar, that about 800 million people incur catastrophic health expenditure, and of which the majority of these are in Asia, the blue-colored part of the bar, and then some of them are then in Africa and also in Latin America. And if you look at how this is split across countries, so take the example of Egypt. This is data from 2015, and the poorest households are spending 10% of their household income on health compared to the richest, which is about 1.4%. The same is the case for Kenya, where the poorest spending much more on health as compared to the richest. So the point I'm trying to make through these 5 or 6 slides is that the challenges of inequities have been in our region for many years, and in low LMICs have really been facing this, and we need to highlight and bring these as equity issues. Now comes in COVID in our countries, and COVID has really exposed the health systems not only of developing countries, but have stretched even the health systems of many developed countries, as we have seen. So I will touch on the next few slides on the work of some South Asian countries that I did. So I had a group from India, Pakistan, and Bangladesh and Afghanistan, and I'll show you some data on how the health systems have responded. But I put an op-ed, I put something in the newspaper in Dawn, the leading newspaper of Pakistan 3 months ago, and I said that tackling the challenge of COVID in Pakistan is like expecting wonders from a fragile health system. And it's really, you keep a health system underfunded for decades, and then you ask it to put a first-rate response. I just don't think that will ever happen. And I said it's like asking a malnourished child to perform well at school. It will not happen. And I think that is the kinds of challenge that many of our countries are facing. So this is the epidemic curve of the 4 countries that I was talking about: Afghanistan, Bangladesh, India, and Pakistan. While there is some information that is coming in that the curve in Pakistan is bending and it's flattening, but it remains to be seen what happens. Eid al-Adha is coming, and last Eid al-Fitr, it was a disaster in Pakistan. We had a huge surge. So we have to see how this goes. But this is the kinds of curves, and in India, of course, it is peaking in a big way. And so it has really thrown bare and challenged the health systems of our countries. So if I were to, what I will do in the next 4 slides, if you allow me, that I will share with you some of the aspects of the health system response that has taken place in these countries. So for instance, if you were to look at the testing capacities of these 4 countries, of course, all of them have been testing at a much lower level than is desired or what many of the other countries have been doing. But if you look at both India and Pakistan in the red color, then the testing capacity in Delhi and Islamabad is much more than in Bihar in India or in the KP province of Pakistan. And that's a manifestation of the inequities as we respond to the challenges of COVID, If you look at the issues of distribution of facilities, then of course, most of these are pretty much situated in the urban capitals. If you look at the cost of the test that is being done, so it has also been allowed to be done in the private sector. And in these 3 countries, which are low middle income countries, the cost of COVID test is around $40 to $50, which is exorbitant, for people to afford. And clearly, if people have to go to the private sector to do these tests, I just don't see how can that happen. In India, in the public sector, it is not free, it is actually subsidized. So these are some challenges that bring out the response that has taken place. I have to say that despite all these challenges, many of these countries, given their limitations, have done a reasonable job. So to say that it is because of the past, the way the systems have been framed and the systems have been there, that it has become a challenge. But with those limited resources, these countries have done a decent job, I would say. The problems have been of ICU beds in these countries. You can look at the numbers, whether it is 400 in Afghanistan or 4,000 in Pakistan or 29,000 in India, being a big country. But there have been plenty of news in the newspaper that many people were unable to secure an intensive care facility when that was needed. And I think those are the kinds of challenges that we have had. And many of these people, you can well imagine, were the people who were the less privileged from our society. Another challenge, of course, there's been so much in the press, and the provision of ventilators has become a hot issue. in many of our countries. I'm not sure whether providing ventilators solves the problem, because many of the situations, we don't have the workforce in the ICUs who are actually being able to use those ventilators. And so that sort of thing has also exposed the capacities of our systems to be able to provide critical care. And many a times people have not been able to receive that service. Thankfully, now the situation in Pakistan is better, but certainly in a few weeks ago, there were these kinds of challenges that we were seeing in our countries. Similarly, the availability even of PPE had become a challenge in countries in Pakistan, but also in countries like Afghanistan and Bangladesh. Of course, these challenges have thrown open the fact that many of our countries have now started working to manufacture things themselves. And in a sense, I would also say that COVID has brought in challenges, but it has also thrown in so many opportunities for us to be doing things that we can actually do, and we tend to rely on external support and external financing. So many of these things have exposed the health systems, but of course there has been a response that has taken place from all these countries. Let me turn lastly on the issue of coherence of policy response. Now, Pakistan, and I think somebody said this in the message, is a decentralized country. It has 4 big provinces. And there was a lack of coherence in policy. The federal government was sending one message, and the provincial government was sending other messages. And that created a lot of confusion in the minds of people as to whether to, for instance, ease the lockdown, to be able to stay with the lockdown, to be able to open businesses, or to keep the businesses closed. And that also happened in other countries. It also happened in Afghanistan. But certainly it was a major challenge that happened in Pakistan. And that lack of coherence, I think, initially did create confusion and problem amongst the minds of many stakeholders. So all this, how do the equity issues then come up in response to COVID-19? And I would like to bring up some issues. So clearly, we know that the older adults in all our countries, developed and developing, those living in densely populated areas of low socioeconomic status, migrants, minorities, those with comorbid conditions were those who were exposed to the higher risks and had challenges when it came. So those were the vulnerable groups in the context of actually getting either exposed to COVID, infected by COVID, or actually getting care when it demanded critical care for these population groups, basically. Similarly, people who were paying low-paying jobs in transportation, in grocery, in pharmacies, who were dealing with the public far more exposed. And even in the case of China, which is, of course, now well behind the epidemic or the pandemic, there were challenges of the population facing out-of-pocket expenditures, or even for those who were insured, till the government had to step in and had to actually take care of these population groups because they were being exposed to catastrophic health expenditures as a result of COVID. Now take the case of India. And in India, which is a huge country, low middle income, it has almost 460 million people living in urban India. And suddenly when the government announces a national lockdown for 6 weeks, you can imagine that people living in the slums and in the bigger slums of the bigger cities of India had huge problems of washing hands, of social distancing, of personal protection, and they were really exposed. I mean, how would they actually be? So in these situations, the deprived populations of even in Pakistan, in Karachi and in Lahore, similar things happened. And so these are the kinds of challenges that populations are facing. I wouldn't be surprised if something similar happened in Cairo. I haven't seen a lot of that in the literature, but having lived in that city for 10 years, I would have imagined that things would be not very different there as well. Similarly, if you look at some of the issues, data that has come from Brazil, and if you look at some of the mortality data from Brazil, so Pardos are Brazilians with mixed ethnicity, and then there are the Black Brazilians. And their mortality was 1.4 times and 1.3 to 2 times higher than the white Brazilians. Now, you can look at all sorts of reasons why they were, but there was clearly a racial effect, a regional effect, an ethnicity effect, and also you could attribute it to the lower socioeconomic groups. And this, of course, has come a lot in both the public media and as well has been published. This is a publication that has come out in the Lancet, which has sort of shown these kinds of inequities as a result of the care of COVID. This is another example of what has happened in the US. And the top line, the green line that you see here, is the mortality that is happening per 1,000 population in the Black population. And you can see that it is around 70 per 100,000 here compared to the white population, which is around 20 per 1,000. That again exposes the inequities in our health systems. So it's not just in the LMICs, but even in the more advanced systems, this has happened actually. So as I come to the close of my presentation, there has been a big dilemma for our country. Certainly this was a big dilemma in Pakistan. And the dilemma was, shall we continue with a complete, stringent, rigid lockdown and flatten the epidemic curve and risk economic collapse in our countries, or because already our economies are at a risk, or we revive the wheel of the economic growth and do smart lockdowns and protect people from getting infected. And underpinning this has been the issue of equity, whether we let people be protected or whether we allow them to have, because there are many, the informal sectors are huge, daily wages are huge, and those were big challenges. And at some point, the government decided to ease the lockdown. There is no one answer, quite honestly. It depends on the country's own situation, but this was a situation which was faced in many, many countries, and I'm sure in the Middle East as well. In Pakistan, before I close, I want to show that what has come out as a result of the socioeconomic challenges caused by COVID, so these are the 140 districts of Pakistan. And the green colored are the protected ones, and the red colors are the ones which are extremely high risk as a result, the highly vulnerable ones. And you can see the disparity across the districts. And this is reflected very much also in the health systems, because clearly the green ones are the urban capitals, the big cities, and the red ones are the remote districts, the Balochistan province, where you see a lot of red color. So these are the kinds of inequities that as a result of COVID, many of our countries have been facing. So to close, the key messages of my presentation would be that health equity issues have clearly been plaguing our countries, both LMICs and EMR, much before COVID, and I think we need to bear those in mind. COVID-19, of course, has revealed, and I would like to emphasize to the heads of governments and heads of states for the first time, the fragility and the vulnerability of our systems. Never before the prime ministers and the presidents of our countries have given so much attention to health as has been shown as a result of COVID. Now, countries have mounted the response to the best of their capacity, but there have been huge gaps as a result of weak health systems. And the particular thing that I would like to emphasize is public health responses have been weak. So the focus has been on ventilators, on critical care, but I think our focus should have been much more on public health responses, surveillance systems, contact tracing, better use of technology, which I still think has remained a gap. And COVID certainly has enhanced inequalities in health and socioeconomic sectors with excessive burdens on the poorer segments of our population. And finally, before I close, I would say that COVID, despite the enormity of the challenges that health systems have faced, as a result of COVID, they have never received such attention as they are received now. And I think we should push, and our governments should seriously consider that this is really an opportunity to move towards more equitable health systems. So while the challenges are there, but I think there is also an opportunity today, and I think we should try and benefit from this opportunity.
Thank you.
I want to thank you very much, and I'll stop here. I'll back to Dr. Musa Ajlouni for the opportunity. Thank you very much, sir.
Thank you very much, Professor Siddiqui, for your comprehensive, informative presentation and pinpointing the inequities in the lower medical income countries, these inequities that are built in the healthcare systems, and they are, if we use the vocabulary, they are endemic. And health systems should start with these issues if we want to bring real advancement and real improvement in the health care and the health of these countries. And I have a question from the audience. maybe it is far from the equity, but I have to raise it. What is the most important positive long term of COVID-19 on the healthcare systems in low and middle income countries? I think that you have mentioned that, but if you please answer.
So I'm sure. I think there are. I think, as I said earlier, the health discussion on health has never taken place in the cabinets of our countries as it has taken place in the last 4 months. And that is, for me, the big thing that we need to cash on. And we as technical people, as academics, as people who are advising our governments, really should not let this opportunity go by. This is, for me, the biggest take home, or not take home, but take away from this opportunity that we have. And so we should make sure that the health budgets of our countries go up, the health systems are strengthened, and we do it with a lens of equity when we actually focus on that. So let's not miss on this agenda. Inshallah, COVID will go in about, or will be less in the next 6 months. But with the new norm, the health systems should be much higher on the political agendas of the Eastern Mediterranean countries and the LMICs.
Thank you very much again, Professor Siddiqui. Now I will turn to Dr. Bassam Al-Umari. He will present us about presentation about COVID-19 and opportunity for health system strengthening in Gulf countries. Dr. Al-Umari, the floor is yours, please, and you have 15 minutes for your presentation, and we will proceed after that 5 minutes for discussion. Thank you very much. Please, Dr. Al-Umari, the floor is yours.
Can you see my screen? Thank you very much, Dr. Musa. I would like to thank Dr. Hannah, who invited me for this opportunity. It's a pleasure to present this after Dr. Rawaf and Dr. Siddiqui, just want to just a small issue with the name. It's Bassam, not Bassam, and I know that it's Bassam is much more common name in Jordan. That's why a lot of people get it mixed up with Bassam. It's Bassam Al-Umari. I'm an assistant professor and faculty advisor at College of Medicine and Healthcare at Khalifa University in Abu Dhabi. What I will be presenting today is, as I've been asked, it's about the United Arab Emirates system and how this opportunity of COVID-19 has been used to strengthen the resilience of a health system. So to look at the size of the global problem, and if we, that would be echoing what Dr. Salman has mentioned earlier. And I've done a little exercise here where I've looked at the data on the 11th of July and then again on the 13th of July, exactly at the same time, which is 1 o'clock GMT. And trying to look at the difference in numbers possibly will make us understand the size of the problem is in more details. So over 400,000 within 48 hours, new cases. Nearly 9,000 deaths within 48 hours. We must always as well look at that recovery, which is over 220,000. All of these cases is in 48 hours. So that shows really that this is not a small problem. This is quite a large problem. Something that we would like always to see is this number here, which is the recovery, is going much higher than this. As long as we can see new cases are much higher than the recovery, we still have a lot of concerns. So within the last few months, we have learned a lot about COVID-19. Yet, I think the next months, years, we still got plenty to learn. Going back, and I would agree 100% with what Professor Rawaf said earlier. There's no expert in COVID-19 yet. Right? All what we know COVID-19 is for the last 9 months. people been predicting, people relying on their knowledge of previous pandemics, but not specifically in COVID-19. Lots of things has been said, predicted, and possibly some of them were correct, some of them were incorrect. So why we are worried about this problem in the world? Most importantly, it's life. We are worried about the mortality rate. We don't want people to die, which is what's unfortunately happening at the moment. The increase of medical error due to resource being stretched, and we have seen that in many countries around the world where they are lacking resources, that is causing a lot of medical error, loss of life, etc. Avoidance of health hospitals and delay in seeking care. We have seen and heard people who suffer from some chronic illnesses. They are worried to go to hospitals. They don't want to see their doctor. They don't want to go to the hospital because they are worried that if they go to the hospital, they're going to contract COVID-19. That is going to cause a worsening in their chronic illnesses that they have. One major concern, and I personally think that possibly it's going to take much more resources to deal with it post this pandemic, is the post-pandemic outcome, which is the physical and the mental impairments or illnesses that people could potentially suffer from. And we have to be well prepared for these kind of problems in the future. So moving to the United Arab Emirates, specifically talking about it as my presentation would focus on, I think we need to look at all statistics in context with the population of the country and in context with the culture of this particular country. The United Arab Emirates population is nearly 10 million, with about 88% of these people are migrant from different places in the world. So far, these statistics were a few days ago, we are hitting nearly 55,000 cases. Something that in the positive side of looking at this pandemic within the United Arab Emirates is the recovery cases. We have nearly 45,000 recovered cases, which is something is quite good, and it's higher than the global rate, which is the United Arab Emirates rate coming to 82%. This is one of the measures that they look at around the world in order to evaluate how countries are dealing with this pandemic. Another measure is the fatality rate, which is 0.6% in the United Arab Emirates. And this is something that, inshallah, we hopefully that will maintain, and even it will go lower, not just in the United Arab Emirates, but in the whole world, inshallah. These curves, if you look at the green line is the recovery cases, while the brown is the new cases reported. And what we always would like to see, and inshallah we'll see that in the whole world, is this green line is on top of the brown line, is on top. That the cases that are recovering from COVID-19 is higher than the cases that are newly reported for COVID-19. So if we look at the East Mediterranean country, which is 22 countries according to the World Health Organization, you're going to see the statistics here for these countries. And I've just wrote this exercise and this slide comparing it to what's happening in the United Arab Emirates for these cases. And if we look at the curves here, the blue one is about the cases reported for COVID-19, and this brown one is the death, the fatality from COVID-19. So it's around the same time, around sort of March, end of March, April, when the cases start going up. Same here is happening in the United Arab Emirates. Then after June, there is a big drop, and then it's going up again here. The thing that would be quite good in context of the size of the problem in the United Arab Emirates, that this line is flattening up a little bit here after May in terms of deaths in the United Arab Emirates. So if we look at this data and we look specifically about after April, why this increase started in here in the United Arab Emirates, okay? And there was more testing and opened several additional drive-through COVID-19 testing facilities. So obviously more testing, they're gonna discover the asymptomatic patients that have contracted COVID-19 and not showing any symptoms. Another increase here is happening over just at the end of May, early June, another number going up. So what's happened there? It's Eid al-Fitr. Again, as I said earlier, we need to look at the context of the culture. Has people been ignoring social distance? Has people been ignoring the use of PPE and the precautions that they should be using? And that's why these numbers has gone up. Then there's a few days here after the 5th of July, you can see a spike up on the numbers there again. And if we think about the reason, is it more testing here? Because in the United Arab Emirates on the 5th of July, they announced that 100% of the federal government staff has to go back to work. And all of these staff, they have to be tested for COVID-19 before they go back. So again, is there a possibility that we have asymptomatic patients again, and we'll start discovering them by enforcing these tests? Well, the term of testing or not testing is quite big. What's coming up next? Eid al-Adha. Has the public learned something? I hope so. So what I want to really be careful about saying all of this, that the relationship and the correlation between these factors is only based on my observation. Obviously, to link them directly to the increased number or decreased number, there is a lot of statistical testing that has to be done in association with other factors that may have impact on COVID-19. So on the 18th of April, the regional office for Europe, for the World Health Organization, produced the documents. This document has 16 recommendations to produce guidelines for dealing with this crisis and strengthening the healthcare system response for COVID-19. The focus, I'm not going to go through this whole slide, but the focus was on from number 7 to number 10 recommendations. Mainly these recommendations were focusing about the availability of resources, about expecting the unexpected, etc. One thing that the United Arab Emirates healthcare system done, that they did not spare any resources in dealing with this problem, right from 1 to 16, even before the 18th of April. How that was done is going to be presented on this next slide. Many of the reports rated the United Arab Emirates to be best in one of the best countries dealing with this pandemic. So what they have done, there was early gradual lockdown response. And I would like to emphasize the point of gradual, because if we don't do the lockdown gradually, then it's going to cause chaos. We have seen that in some countries where they don't allow people to go out from their home. They said, you know, this particular time stop, you can't go out, and people go absolutely all over the place trying to get their shopping, etc. So these kind of measures has to be gradual, otherwise it will cause chaos. The early national COVID-19 sanitization, the availability and accessibility of tests. Okay, the test is provided free in the United Arab Emirates for any person who's been in contact with a COVID-19 patient or has been traveling recently or presenting symptoms that are related to COVID-19. They were building test centers. By the 14th of May, there was over 1.5 million COVID-19 tests have been conducted across the United Arab Emirates. I know that testing is a controversial topic that many possibly would agree or disagree that we shouldn't do mass testing. One of the issues with the testing, that the test is valid at the time it's being done, right? Apart from talking about the specificity of the test, that there is false negative or false positive, but actually someone could go and do the test and prove negative, and half an hour later come in contact with a COVID-19 patients, and then they become positive, right? So the measures that we can take always, they minimize the risk. There isn't a single measure that we can take to eliminate the risk completely. The availability of the PPEs were available for healthcare workers and for the public. There was no shortage of that. Maintaining the availability of non-COVID-19 related treatment, and this is extremely important. And that would be echoing to the point that Professor Salman said earlier, that we need to look at other issues that we need, other treatment that we need, not specifically only for COVID-19, but some of my colleagues have heard in some of the hospitals, they needed extra supply for some of the renal medications that their patients taking, and they made sure that these resources were available for the hospitals. Increase the supply of the resources for the pandemic, and the national campaign for mental support. And again, this is extremely important because we are dealing with a problem that we may have to deal with the consequences of COVID-19 post this pandemic. Effective communication with the public, $5.5 thousand nearly the fine for some of people who would post false information on social media. And I think this is extremely important because it caused a lot of problem in the world. How I'm saying that these guidelines were achieved in the United Arab Emirates system, healthcare system. It's even before the 18th of April. In early March, they started building new medical facilities to help treat COVID-19 infection. Some of these medical facilities were built in some industrial areas. On the 8th of March, schools were shut and start distance learning. 20th of March, the first 2 deaths were announced. 28th, new testing sites opened. By 10th of April, Abu Dhabi service company, which is Saha, announced an opening of 13 additional COVID-19 test centers. So what we've learned so far, always prevention is better than cure, and there's nothing different in the COVID-19 than any other pandemic in the past. We need to prevent this disease rather than dealing with curing it. Patients and public informed decision-making process and involvement is a vital attribute here. Now we are relying on people understanding of the size of this problem to try to prevent it. Considering the margin of error in COVID-19, which is basically what I've said earlier, the false negative. Okay, someone could be false negative and going around spreading the disease to other people. If we don't take these measures, cultural impact is extremely important. Public education regarding preventing and minimizing the spread of the virus is vital, and the use of the PPE and social distancing. What we need to do potentially from now on is be productive while be cautious at the same time, which I think it's a key factor for dealing with this problem. We can't shut down economies, shut down all countries, or they have to open. Some people will have to go to work. So we need to still be productive, but at the same time with caution. Expect the unexpected and be prepared. And on top of all that, I'm just going to emphasize one extremely important problem here, which is public education. I think public education is the key in dealing with this problem. If the public does not cooperate, then it is a big. Now I'm finishing with this with a virtual handshake, so keeping the distance. And thank you very much for listening.
Thank you, Dr. Al-Omari, for your comprehensive presentation. And if you allow me just to point one issue or one remark from your presentation, very important. I think that available of resources by itself, I think, as you mentioned, are not enough. The major or the main issue is how resources, if well managed, make differences. And you illustrated the case or the experience of the United Arab Emirates. and how they respond successfully to the COVID crisis, and they manage it properly according to WHO guidelines and the best practice, and therefore they utilize and manage their resources in a good way. I will take one question and ask you before that. Can you give us some examples for successful collaboration between the Gulf countries during COVID? Just one example, if you can recall, so that you can benefit from the experience, if there any facet of collaboration between Gulf.
I think the main example in the collaboration is similar to the collaboration between the United Arab Emirates and the rest of the world, not specifically only the Arab Gulf, which is exchange of resources, exchange of experience, right? And one very important thing that was potentially could help and aid countries is what we are doing now. It's something similar to what we are doing now. We are exchanging experience, exchanging resources, what's happening and what worked with one country and not working in another. One of the main issues we have now, and I will focus on this point, we do not have COVID-19 expert. The expert in COVID-19 at the moment is a 6-month-old expert in this particular illness. So without collaborating with each other for us and being able to come out with some sort of outcome, what worked in our experience, I think it will be a major issue.
Okay, thank you very much, Dr. Al-Omari, and thank you all speakers. Now, if you allow me, we will open the open discussion for 20 minutes. And to start with Dr. Rawaf, you have 2 questions, if you allow me. The first question, how do you see the importance of research for evidence-based response to the crisis? This is from the audience. I know that you have elaborated on this, but if you can more elaborate. Thank you.
Salman, you're muted.
Yes, Dr. Rawaf.
You are muted, Salman. Unmute yourself.
Thank you very much. It's a really very good question. And
you are muted, maybe.
Can you hear me?
Yes, now you are. Yes.
So
go ahead.
To be very honest with you, we are dealing with a new virus. We are dealing with a new dynamic. And I don't want to elaborate in a way that people may misunderstand that actually until today, we don't have full understanding of the physiopathology of the virus. You know, we need to accept that a lot of things which we are discussing now today may change, you know. And it's changing because until, if you take the background of it, this was seen as a respiratory disease. Started with outbreak of pneumonia in China. We believe it started about 3-4 months before China emerged. Okay? As a matter of fact, I want to go a little bit further. There is some evidence, actually some cases reported about a year ago, maybe more. You know, and so it started to emerge. But today the virus is not a respiratory disease because the whole focus, all the countries talking about respiratory disease and you diagnose it. It's actually systematic. You know, in particular, immediately once it's entering the lung, this is where the virus started to spread. Of course, it's leaving damage a little bit in the lung here and there. But actually the bigger damage, which is risking our life and the life of everyone infected with it, is more complicated than that. My second point about this virus and the evidence is very important. And I'm very pleased this is initiated by colleagues in the region, in Emerald, you know, that from the beginning we felt this is a virus which will not simply by discharging the patient from the hospital will disappear.
Thank you.
You know, data today showed very clearly, it's published today actually, showing very clearly, and somebody was on television, I was told, talking about this is a condition which may leave damages for some time to come. Some of it may be, we don't know, permanent, you know. This is not, by the way, this is not SARS-1. So people, they say, look, we have experience with SARS-1, we managed it, you know, everything's fine. No, it's not. Genetically, they are connected, but it is not SARS-1. So that is my second point, which is when I said a new virus, but also a new dynamic, which is in which we are not fully versed, you know. So maybe it's a bit early to make any judgment, but of course we have to adapt to the reality as we are learning step by step.
Thank you. The second question, Professor Salman, how to increase investment in health in low-income settings to respond to COVID-19? What ways?
It's a very good question, again, and I would leave it to the judgment of government. You have to balance between how much damage in any pandemic or even epidemic locally that will cause to the fabric of society, that will cause to the economy, you know, and whether you will shift some of the resources from something which may not be fully necessarily or needed to health services. And I think Professor Siddiqui said it beautifully, you know, that this pandemic, despite the huge disadvantages, waken up our senses that we started as ordinary citizens feel how important health is. Government, as he said beautifully, eloquently, that are now more in tune with the thinking about strengthening health system, putting more resources into public services. Because what happened over the last 10, 15 years, you know, all of us noticed it, and Samin was leading that at WHO for many years, government shifting the responsibilities from their own to the public, to the individuals, without thinking of the consequences to the person and the long term. And I think that hopefully will change. But unfortunately, I know, and you know, human beings, they have short memories. They don't have long memories. Hopefully by the time we fully recover, not go back to the stupid gear and say, oh, everything is okay. Let the people look after their health. No, you should look after my health, and I will be also responsible. It's about shared responsibility, and the government have an important duty. And let me finish with this. Services in any country, and I know this is controversial, I said it once in Bahrain about 21 years ago. Services which is not fit to the king and his families, to the prime minister and his families, to the president and his families, does not fit to any individual in that country. Ask your president, ask your king, use our service in this country. If you go to Germany for treatment, then you are ignoring all the medical profession in that country, and you are giving the message the service is not suitable for everyone.
Thank you, Professor Salman. May I add again to this question about increasing investment? I think better utilization and better management of existing resources and allocative efficiency, if you agree with me, and technical efficiency and proper utilization of existing resources will make difference. Do you agree?
that possible, but that a twinkle, you
Yeah.
know. It needs a real investment. Look at public health. I mean, colleagues mentioned it. Look at public health in this region.
Okay.
You know, look, we were looking for, honestly, through the Arab Public Health Association, and you know, we asked, where are the epidemiologists who can give us projection on what's going to happen in 2, 3, 4 months? Until now, we didn't have any calculation which is actually developed within our Arab countries, the 22 Arab countries.
Okay.
We are relying on the Institute of Health Metric and Evaluation from secondary data which we supply. Where are the people who actually did research to tell us why we are different? Because everyone's saying we are different. Yes, okay, you are different. Why? You know, and so on and so forth. No, it needs real investment. It needs real money. It needs people to put the cash on the table to develop the services that people actually need. I don't want anyone to talk about essential services or basic services which are not defined. I want people to talk about comprehensive services, the services every citizen needs. You cannot say to me, this is services you don't need. No, the services I needed, it must be provided by my system.
Thank you, Professor. Thank you. One question for Professor Siddiqui, please. The question says, people in poorer countries are more exposed to the pandemic. What kind of health system structure reforms is necessary to bring about long-term sustainable change in primary prevention to minimize the pressure on secondary and tertiary care? Yes.
So, to be honest with you, I mean, Salman has very nicely in his last response alluded and, you know, to what needs to be done, basically. We can discuss it at two levels. One is the more policy level, and the other is the more, how do we actually make it happen? So clearly, I mean, if you're looking at low-income countries, you know, we have to look at the level of spending of these countries, you know. I mean, even if you take countries like Egypt, or if you take countries like Morocco, or if you take countries like Sudan, I mean, they're still spending fairly less on health. And of the total expenditure that they have, a big part is coming out of pocket in many of these countries, you know. So I think we have to have what is called, number one, a financing reform, which needs to look at how we can actually address the financing challenges, which is what Dr. Salman was calling the investment issues around that, you know. But along with that, I think is a governance reform which our countries need. And frankly speaking, this is an area which is not being given the attention either by WHO or by us, or, you know, and so how do we actually strengthen our ministries of health? How do we ensure, and I would like to bring in this word, greater accountability in our systems? So while equity is even part of our religion, I mean, we are mostly Islamic countries, and adala and equity and, you know, fairness is part of this. But frankly speaking, I don't see accountability. And I think that's the big gap that we have in our countries. Now, don't ask me, I mean, we can have a long discussion on how do we enhance accountability. And I can, you know, that's an area where I interest, but unless we improve accountabilities, we will not be. So a financing reform, a governance reform, and a combination of these. For instance, I mean, I can talk a lot about decentralization of our countries. If we do it, how well are we doing it? Is it effective? Does it make a difference to people at the ground level? And look at Sweden, I mean, a country which is amazingly decentralized. The other point which I want to touch, and Musa, you did talk about that, and you refer to it as technical efficiency.
Yes.
So I would simply say by saying this, that both we need more money for health, but we also need more health for the money that we have. So I think it's both ways that we need to do. So we need to spend our money better to get more health, but we also need to get more money to be able to give more health to the people. I can speak because this is a subject interests me a lot, but I'll stop here now.
Thank you. Thank you. Last question for Dr. Bassem Al-Omari. Dr. Bassem Al-Omari, please. Yeah. How did the United Arab Emirates strengthening the capacity of the health system while maintaining quality health services. Is this due to the UAE being a high-income country? Is it because of the wealth of the country, the abundance of resources?
Well, I don't think it's necessary. Obviously, the economy being strong will always help, and it is vital to assist in these kind of problems. I think one of the main issues in dealing with this problem at the moment, we don't have time for negativity. Negativity is, I've noticed some of the comments about people saying, oh, we are presenting what's happening in the United Arab Emirates, it's a wealthy country, etc. It's not about negativity, it's not about wealth. It's about what works. We don't know what is this disease is going to cause in the future. It's causing disaster in the whole world at the moment, but we don't know what further consequences is going to happen in the future. There was no COVID-19 few years ago. I'm going back to Dr. Salman's point. This is not SARS. This is a completely different problem. So if we don't look at each system and what worked with that system and try to copy what's working and try to implement this within our context, then we're going to be in a lot of problem. One of the main issues we have at the moment, we don't have any evidence-based. Research takes long time. Where is the evidence? The evidence is only based on people experience, what people are experiencing, and there are countries are copying, and strategies that countries are using are copied from one country or one place to another. Even the World Health Organization is presenting what is working in some countries and what is not working in others. In relation to the test being done massively in the United Arab Emirates, this has been done in many other countries in the region, not just in the United Arab Emirates. It's been a big debate in Europe or in America or some of the Western countries if they should test or they shouldn't test.
Thank you. Thank you, Dr. Al-Umari. Before I give the ground of the floor to Dr. Mohannad for his conclusion remarks, I would like to conclude that we shape, a saying that I agree with it fully, we shape our systems and afterwards our systems shape us. Therefore, let's now start to reshape our healthcare system all over the world, not only in lower and middle income countries, all countries of the world after COVID-19, they need to reshape, to redesign, re-engineer their healthcare systems to be less expensive, less mechanical, less institutionalized, less disease and tertiary oriented, less profit-driven, less harmful, less corrupted, let's say it, less provider-geared, and less rigid. And it should be for more human, more equitable, more accessible, more safe, more transparent, more universal, more community and consumer geared, more evidence-based, more cost-effective, more wellness and primary healthcare oriented, more user-friendly and more adaptable. The question is, how can we achieve all of that? I believe that by good governance and professional management, we can reshape our systems to achieve all of that I mentioned. Thank you very much for this fruitful presentations, discussions. I learn, and hopefully we all of us learn more, and I hand the ground or the floor to Dr. Mohannad. Dr. Mohannad, the floor is yours.
Thank you very much. I would like to thank our esteemed speakers, facilitators, and audience, and wrap up with few key messages. I will start with the Professor Tamim message for today, which is very interesting and very well stated. COVID-19 have revealed to heads of governments and the states the fragility and vulnerability of their national health system. I think this message should go with us home. And he stated very nicely that bridging the gaps and combating inequality is vital to leave no one behind. We must go for more social justice, gender equity, and the human rights things. From Dr. Salman, I think Dr. Salman very nicely stated a very big problem in our region related to the private sector. We do not see the private sector in the engaged. So the crisis pointed out the importance of collaboration among different private and public health sectors and community engagement for the public good. Also, a very interesting message that we need to maybe take with us home, the COVID-19 pandemic transformed the acceptance and use of digital health systems or technologies and shifting toward providing remote services to the patients while they are in their homes. Very interesting message that it's not only related to the resources. And this came message from Emirates, our colleague from Emirates, that we need to do more with other components of the health system. Of course, you know, we have more, but I think we have, time is over for today. At the end, I would like to thank you all, and we hope to meet you again in one infinite future webinars. Thank you very much. Appreciate it. Thank you. Have a nice day.
Thank you.
Bye-bye.
Thank you. Thank you all.
Thank you.
Thank you.